Welcome everyone to this patient-focused webinar. My name is Jason Lakis from INSIGHTEC. I'm pleased to be a part of today's virtual educational event. Please be patient as we take a few minutes to allow everyone to get signed on. The presentation will begin shortly. Welcome everyone to this patient-focused webinar. My name is Jason Lakis from INSIGHTEC, and I'm pleased to be part of today's virtual educational event. Please be patient as we take a few more minutes to allow everyone to get signed on. The presentation will begin shortly. Okay, looks like we have a great number of attendees signed on, so let's begin. The goal of today's presentation is for educational purposes. We are very fortunate to be hearing from both Dr. Jean-Philippe Langevin and Dr. Natalie Diaz as they discuss focused ultrasound as a treatment option for patients diagnosed with essential tremor and tremor-dominant Parkinson's disease. As questions arise during the presentation, please utilize the Q&A button located on the bottom of your screen. We will have time after the presentation to answer all the questions that are asked within the chat. So let me begin by introducing you to today's presenters. We have Dr. Jean-Philippe Langevin. He's a board-certified and fellowship-trained neurosurgeon specializing in the surgical treatment of movement disorders, epilepsy, and psychiatric conditions. He was selected as a 2016 Super Doctors Rising Star and achieved the Super Doctor designation again in 2017. He has extensive experience using neuromodulation to treat conditions such as Parkinson's disease, essential tremor, dystonia, epilepsy, and OCD. He employs a variety of treatment modalities, including deep brain stimulation, vagal nerve stimulation, interstitial laser ablation, and now MRI-guided focused ultrasound for essential tremor and tremor-dominant Parkinson's disease. He's the director of the Restorative Neurosurgery and DBS program at the Pacific Movement Disorder Center, located at Providence, St. John's, and Providence Little Company of Mary Medical Center, Torrance. Thank you, doctor, for being here. We also have Dr. Natalie Diaz. She's a board-certified neurologist with fellowship training specializing in movement disorders. She also has specialized training in the evaluation and programming of deep brain stimulation as a treatment for Parkinson's disease, essential tremor, and dystonia, as well as the therapeutic administration of Botox injections for non-cosmetic indications. Her research focuses on industry-sponsored clinical trials in Parkinson's disease and other collaborative clinical projects in the field of neurodegenerative disorders. Welcome, Dr. Diaz and Dr. Langevin, and thank you for presenting this evening. The floor is now yours, Dr. Diaz.
Great. Thank you, Jason, and welcome everybody for joining us today. So, we're going to be jointly discussing some of the advanced therapies that we have in some of our movement disorders, focusing on a very exciting new program that we're going to have here at Providence Little Company of Mary. As Jason mentioned, I'm a board-certified neurologist. I've been in practice for over 20 years. I did a fellowship in movement disorders at UCLA and was on UCLA faculty for many years. And now have been with the Pacific Neuroscience Institute here in Torrance with Little Company of Mary since about 2019. So I'm going to focus on the medical aspects here. I'm going to talk a little bit about some of our movement disorders, especially essential tremor and tremor-dominant Parkinson's disease. How do we recognize them? How do we treat them? And who would be good candidates for some of our advanced therapies. So let's start with essential tremor. Now, essential tremor is considered one of the most common movement disorders. It's estimated that about 10 million Americans live with with essential tremor. It is very common, and there's a bimodal age of onset of essential tremor. We know that there are people that start very young. I have patients in my clinic that can tell me they've had tremor since they were children. For some people, it presents in their mid-age years, and some people can present very late in their life. We don't exactly know what causes essential tremor. Unlike some of our other neurological diseases, there is no classic sort of changes in the brain that we can say everybody has. What we believe is that we have certain cells in our brain that have a tendency to have an automatic rhythm or rhythmicity, and it's controlled and kept in check by the brain, just very much like the heart has similar cells. And with changes that happen in the brain, these cells are sort of unleashed and start having rhythms that become strong enough that are transmitted down the body into the extremities. And that's what we believe is the cause of essential tremor. We think that there is a very strong genetic component to this condition, even though we don't have a genetic test or we don't have a specific gene we can test for yet. We know that at least half of the patients that have essential tremor can tell us that they've got multiple family members with tremor, parents, siblings, grandparents. So we know that genetics plays a strong role. This is a condition where for our diagnosis, we need tremor in the hands, generally tremor that affects both hands. And it tends to be a type of tremor that comes out when the hands are doing something. Can be writing, can be eating, can be brushing your hair, it can be any sort of daily activity during the day or holding something. In about 20 or 30% of cases, people may also have tremor in other body parts, such as a head tremor or a voice tremor. But we definitely need hand tremor to make this diagnosis. And it's a tremor that, even though it is not considered a fatal condition, this is a tremor that over the years worsens, becomes a higher amplitude tremor, and can get to the point that it interferes with these daily activities. How do we diagnose essential tremor? Where it is mainly a clinical diagnosis. There's no one specific test that we use. We take a good history when people come to see us in clinic. We do a good examination, very much like what you see in this gentleman in the video. We have people hold out their hands in certain postures that bring out the tremor. We might have them hold a cup or hold a pen or something so we can see the tremor in all its glory. We might have them write or draw spirals, as you'll see in a few minutes. And this is the type of tremor that we're looking for. If we see somebody that's got a head tremor or a voice tremor, or they go to stand and we see a little bit of bobbing in the legs, that's also can be part of this condition for about 30% of people, although not everybody. Again, we don't have a specific test to help us diagnose essential tremor. We look for these clinical findings and we try to exclude other causes, such as, sometimes if people are drinking a lot of caffeine during the day, they can have tremor in their hands. If there are certain medical conditions, liver and kidney disease, thyroid disease, that can bring out some tremor. If people are chronically on certain medications, such as steroids for chronically, they're taking inhalers or other medications like theophylline for asthma, they're on amphetamines either for ADHD or for wakefulness, and some psychiatric medications as well, including antidepressants and anti-anxiety medications, can sometimes bring out tremor. So we try to look at all these things, exclude things that can bring out tremor. We might do some testing of some of their organs, such as liver, kidney, and thyroid, and make sure that we're not looking at a secondary type of tremor. I'll also put in there that sometimes Parkinson's disease can be confused with essential tremor, and I'll talk a little bit about that in just a second. So once we make the diagnosis of essential tremor, what are the options that we have for treatment? Well, there's a lot of people that live with essential tremor that their tremor is mild enough that they don't seek help. So they just live with it and they're able to manage, and so they don't want any treatment at the time. But when the tremor starts to affect their activities or it becomes bothersome enough, then they seek medical treatment. We always start with a discussion about some of the medications that we have available. Generally, we have beta blockers. This is one of our first-line therapies, medication called propranolol or Inderal. It's been around for several decades. Sometimes we can use newer generation beta blockers such as metoprolol or Natalol, and these can be very helpful for reduction of tremor. Other options can be anti-seizure medications, the main one being primidone, and some second-line agents can be gabapentin or Neurontin, topiramate or Topamax. And we try to stay away from some of the medications for anxiety, such as clonazepam or benzodiazepines, as they have a lot of potential complications. These are the main ones that we offer patients. We pick and choose them depending on the patient's age and what other comorbid medical issues that they have. As I'll talk about in a little bit, sometimes these medications offer benefit, and for some people they don't. Unfortunately, they can sometimes have a lot of potential side effects, sedation, dizziness, mental fog, moodiness. On a rare occasion, they can cause hallucinations when people are older, and they can have some interactions with other medications. For example, primidone can't be taken if somebody is on a blood thinner because it can alter the metabolism of the blood thinner. We also have what we call assistive devices. So if people are having a lot of trouble eating or writing, there are heavy-weighted eating utensils, heavy-weighted spoons, knives, forks. There are also vibrating utensils that try to cancel out the tremor. There are gloves that have weights that can help dampen down the tremor so that people can do their activities a little bit more easily. We have what are called adaptive tools. There can be clothing that is snap instead of zippers or buttons, shoes that are Velcro instead of tying. There are also writing aids, for example, keyboards that have large buttons so people aren't double tapping. There can be programs you can put on your computer, computer mouse to help cancel out the tremor. And then there are also wrist-worn neurostimulators such as the Cala IQ device that stimulates certain nerves to the brain and give people temporary relief, about an hour or two, to help people give little snippets of time of reduction of their tremor so they can do their daily activities. I almost always involve my allied health colleagues, physical therapy and occupational therapists. They can be very helpful in helping people strengthen their limbs so they feel like they have better control. Occupational therapists are very good at helping people develop other strategies for doing their daily activities to make simple things a lot easier. They also will have, some of these assistive devices and tools and utensils in the studios so that people can try them out and see how they work and help them order and get them ordered under their insurance. So when somebody comes to us with a tremor that is getting in the way of their ability to do things, these are all the tools that we have available to us to help somebody adapt to their tremor and help relieve their tremor. But unfortunately, of people that have at least moderate essential tremor, they don't get enough relief from these medications. Our expectation is that people are going to get about 50% of relief, reduction of their tremor, especially if they have moderate to severe tremor. Some people get no relief at all. So I have patients that we max out the medications and do not feel that they get much relief from these medications. So some people are intolerant to these medications as well. They're unable to tolerate the side effects. They're too sedating. They cause mood changes. They make them feel dizzy. So the medications leave a lot to be wanted here in treatment when people have moderate to severe tremor. And then a lot of people just stop going to see their doctors, either because they don't feel they need it, they don't feel that medications have helped, they don't feel like there's anything else available to them. And as I mentioned in the beginning, even though this is not a fatal condition, over time, if the tremor can get worse, it can cause a real impact on somebody's quality of life. People are become embarrassed over their tremor. They might withdraw from social events. They have difficulty doing their jobs, manual jobs, or if they do presentations where tremor can come out. Tremor sometimes gets to the point where people may lose their independence and have to rely on others to help them with simple daily tasks. And so this can really impact somebody's quality of life if tremor becomes prominent. I will mention, as I mentioned in the beginning, one of the conditions that is approved for focused ultrasound sometimes can be confused for essential tremor, especially in people that are over 40, is Parkinson's disease. Now, this is a much less common condition than essential tremor. It affects about 1 million Americans, so about a tenth of ET. It has a much less lower risk than genetics in Parkinson's as opposed to essential tremor. Only about 10%, maybe 15% of people have a strong genetic component. Tremor tends to be different than essential tremor. It tends to be a tremor if it affects the hands, or it can affect the legs, whereas in essential tremor, it doesn't often affect the legs. It tends to be more one-sided or asymmetrical, tends to be a tremor where somebody is resting, watching TV, in conversation, and the hand will just tremor, or a thumb may tremor, or the fingers may tremor. People may also have tremor in the jaw or the lips as well when they're just sitting and resting. And these tremors tend to get better as they do something, as they complete an action, which is different from the essential tremor, where tremor gets worse when somebody is in action. Now, in most people with tremor is in Parkinson's, tremor is, there. It's bothersome to a degree, but it's not usually the main issue that they struggle with. But in about 50% of people, tremor can get to a point where it can really start to bother them and impact their daily activities. A lot of people with Parkinson's not only can have a tremor at rest, but they can have a postural tremor where holding something can become difficult and sometimes can spill over into their activities. And tremor in Parkinson's disease tends to be a little refractory to some of the medications when it becomes more severe. Oftentimes, for us as clinicians, it's easy to separate out Parkinson's disease from essential tremor. People with Parkinson's disease tend to have other symptoms that are not present in essential tremor. For example, they may lose facial expression, their voice volume may change, they may have changes in their posture where they hunch over, their walking can become slow and shuffled, or they may freeze when they're walking. They may not move their upper body. And so many times when people come to see us in their clinic with tremor, these are all the clinical signs that we use to help separate out Parkinson's disease from essential tremor. But there is a population of patients that, especially in early Parkinson's disease, that can present with tremor that is there for several years before some of these other symptoms are there. And that tremor continues to get worse and become prominent throughout their condition. And so in some people, it can be difficult clinically in our clinic to separate out these two conditions. So we do have some tools that are available to separate out essential tremor from Parkinson's disease. We have something that's called a DAT scan. We have this available here at Little Company of Mary through our nuclear medicine department. People that have Parkinson's disease lose a set of brain cells deep in the brain that produce dopamine. That's what we see here. And so somebody that does not have Parkinson's disease, for example, has essential tremor, these groups of cells should be normal in caliber. For example, they'll have what's called a comma-shaped area of the brain, whereas somebody that has Parkinson's disease and loses some of these dopamine-producing cells, we get the semicolon or the comma-shaped here. So we use this test to help separate out essential tremor from Parkinson's. And here at Little Company of Mary, we actually have an extra program, which is really wonderful, that's called DatQuant, that goes with this. And it tries to quantify the amount of dopamine producing cells that people have and see if it's outside of the range of where it should be for their gender and age. So it's an extra tool that helps the radiologist and the clinician sort of decide whether it's Parkinson's or another condition like essential tremor. There's also skin biopsy that's available that we do here in the clinic. It's a very simple procedure that we do using a little punch tool, as you see right here. In somebody that has Parkinson's, we can find this accumulation of little proteins in the little nerves of the skin. And so we take 3 little tags of skin under just local anesthesia from the skin, and we send them off to the company. And in somebody that has essential tremor, their skin biopsy will be normal, and somebody with Parkinson's disease will see these accumulations of protein. So in those patients that have a lot of tremor and we're sort of on the fence, do you have Parkinson's disease? Do you have essential tremor? These are tools that we can use. The treatment of Parkinson's disease can be very different from essential tremor. As these patients lose their dopamine making ability in the brain, we use more dopamine-based medications. That's the mainstay of treatment for Parkinson's disease. Medications such as Sinemet or carbidopa, levodopa, and synthetic dopamine agonists that simulate dopamine. We can also use a few other classes of medications that sometimes can be a little bit better for tremor in Parkinson's disease, like anticholinergics, amantadine. And if somebody has very prominent tremor that spills out in activities, we sometimes will borrow from essential tremor drugs such as beta blockers and anti-seizure medications to help treat their tremor. We also use a lot of our rehab specialist physical therapy and occupational therapies to help with tremor and mobility in Parkinson's disease. So what do we offer these patients that have essential tremor or have tremor-dominant Parkinson's, where tremor is their main symptom, when tremor is really interfering with their daily life and the medications that we have at our disposal don't help or are not effective enough, or patients are not able to tolerate the side effects? That's when me as a movement disorder specialist, I refer to my neurosurgeon colleague, Dr. Langevin, to discuss some of our advanced therapies for tremor. There are 4 types of surgeries that are available: radiofrequency thalamotomy and stereotactic radiosurgery, excuse me, gamma knife, have been around for a very long time. They're not used as often in this country anymore, just because we have better, safer, more precise tools, but they involve either a surgery where an electrode uses a radio frequency to create a thermal lesion in a part of the brain that is the relay station for tremor, or we have a non-invasive gamma knife where radiation is focused into that same part of the brain, that relay station, to create a lesion. But these involve surgery, these involve radiation, and so we now have better advanced therapies for treatment of tremor. Deep brain stimulation has been around for over 20 years and can be very effective for people that have tremor, essential tremor or tremor-dominant Parkinson's disease. It's programmable over the years, but it is a surgical procedure. It does involve implantation of brain electrodes and a generator, a pacemaker-like battery with a little wire that goes under the skin. It does involve somebody coming into the hospital and staying overnight, and general anesthesia, and can be a very great therapy for people with tremor. But unfortunately, some people don't want surgery, don't want the invasiveness, or maybe are not great surgical candidates. And so more recently, We have focused ultrasound, MRI-guided focused ultrasound that was FDA approved in 2016 for essential tremor, and later in 2018 for tremor-dominant Parkinson's disease. And I'm not going to say too much about it. I'll leave that to Dr. Langevin. But just to say this is a less invasive option. It's there's no surgery involved. It's incisionless. There's no hospital stay or anesthesia. It's outpatient procedure that's done in one day, and so can be a very great option also for people who have very prominent tremor that have failed medical therapy or just don't want an invasive therapy. Who would be a suitable candidate for focused ultrasound, since that is the focus of our talk today? I look for patients that are confirmed with a diagnosis of essential tremor or tremor-dominant Parkinson's. We've excluded other causes. They've had this condition for a couple of years. All the clinical signs are consistent with these diagnoses. They are adults at least 22 years old with essential tremor, or over the age of 30 with tremor-dominant Parkinson's. They must have tried medications for tremor and Parkinson's disease to be able to qualify. So patients that have never tried any medications, unfortunately, we do not recommend going straight to these procedures. So we generally will try medications first, and for some people that works very well. But either they don't tolerate them, or they're not enough, and the tremor limits their ability to do their daily tasks. We do need people, this is an MRI guided procedure, so we do need people that have no contraindication to being in an MRI scanner. So they're able to lie down, they're able to tolerate being in an MRI scanner, they don't have a lot of orthopedic issues, they don't have severe claustrophobia, need sedation, significant sedation to be through this. People need to be awake during this procedure, and it's graded to the patient, as Dr. Langevin will talk about. So we do need people awake and being able to communicate during this procedure and able to tell us how they're feeling. So in summary, tremor can be a very disabling symptom that interferes with daily life activities and quality of life. The tremor, even though it's not fatal, over time can affect people significantly and impact their lives. In patients with essential tremor, medications only offer about a 50% reduction, and if their tremor is significant, moderate to severe, medications may only offer minimal efficacy. And in about 50% of patients, they don't experience any benefit from the medications. More than 50% of people with Parkinson's can experience bothersome tremor, and if it's very moderate to severe, also can be refractory to medications. And when medications and other therapies don't provide adequate relief, we do now have some wonderful advanced therapies such as MRI-guided focused ultrasound that can be an effective option. So I'm going to hand over my talk to Dr. Langevin. If anybody has questions for me, please put them in the chat. We'll do them at the end. Thank you.
Thank you, Dr. Diaz. Dr. Langevin, you can go ahead and share your screen and begin when you can. Thank you again.
Good evening, everybody. I'd like to thank everyone for coming in to joining us today. We're excited to launch this new program on focused ultrasound over at the little company in Mary. So I'm the neurosurgeon who performs these procedures, as well as deep brain stimulation, as Dr. Diaz mentioned. So on my portion of the talk, I'm going to be focusing on like the technical aspect of focused ultrasound. So like a little bit like how does it work? How do we perform the procedure? And then essentially going over the risk and benefit of the procedure. So this slide essentially just to show that although the therapy is gaining popularity currently, it's actually been around for a little while. So like the company and the initial treatment was completed over 20 years ago now. And the FDA approval was obtained approximately like a decade ago already. But the company has, along with a lot of institutions at the U.S., have done a fair amount of research over the last few years. And one thing that we wanted to be sure was the longevity of the benefit from the therapy. So we knew, from the first approval that indeed, like focused ultrasound was able to treat tremor. But some of the questions were like, how long is it going to last? So like you receive the treatment, you go home, you feel better, but are the benefits, maintain over time? And so now that it's been, over 10 years that the treatments were first completed, we have more information, and the studies are finally coming out showing that indeed the benefits are maintained over time. So we feel comfortable offering the therapy over the solid weight right now.
Dr. Langevin, I apologize to interrupt. Could you please put your in presentation mode, if possible?
Oh, okay. I'm sorry. So I probably am not sharing the right portion.
You're sharing the screen. We could see the screen. Just if you could put it in presentation mode, I believe should be in the upper right corner, I believe.
Let me try something slightly different. Is this better now?
Yes, that's excellent. Thank you very much.
Sorry, it was the wrong screen was being shared here. So, this thank you for letting me know. So, like this slide shows here the therapy in action. So like what we are, how we are performing it. So you can see on the top left, essentially an MRI environment. So potentially some of you have already undergone an MRI, but the patients are laying down at this table, and the head is inserted inside this large circular machine, and the images are acquired at that time. The difference with the focused ultrasound is that you can see on the table like these two pieces that are included. So there's the frame, so the slight gold ring, and then the ultrasound itself, the larger piece of equipment right above the area. So this is the portion of the equipment that's going to deliver the therapy, delivering the ultrasound. The MRI itself has really two roles in this therapy. One is to show the anatomy or the area of the brain that will require treatment. So guiding us basically to direct the ultrasound at the right place. And the second role for the ultrasound is to act as a thermal map. So like the MRI is able to actually show us the temperature of the precise location in the body that's receiving the treatment from the ultrasound. And so that helps us determine once the therapeutic dosage was delivered to the brain according to the studies that have been performed. And so on the bottom left, you can see a little bit rendition here, like of what the therapy does. So like from this helmet that delivers ultrasound, so multiple rays of ultrasounds are directed in one precise spots that requires a treatment, and only that regions that receives all the rays, if you will, or all the waves of ultrasound where it's concentrated, only that small areas of about 2-3 millimeters is actually going to receive the therapeutic dose. And that's where we see the temperature being elevated up to the regions where the therapy receives a full benefit. So again, just an animation showing the patient being transported inside the MRI machine. This is the calculations that we make based on the MRI to locate our target inside the brain. And at that point, the ultrasounds are being delivered to that region. And the delivery of the ultrasound is done slowly such that we can evaluate the patients during the therapy. So at times, the patient comes out of the MRI machine, and then we can have them draw like those spirals, so like before the treatment. And then once they receive a sub-therapeutic dose, but still enough to inactivate the brain temporarily, we can see significant improvement in the tremor. So then we feel comfortable that we're targeting the exact location that we want. And at the same time, we ask the patient to confirm that they don't have any side effects from the ultrasound, and before delivering the final dose at the same precise location. So now we just wanted to show this video that was put out by INSIGHTEC, the company that makes the ultrasound, of a patient who is explaining his experience, essentially going through the therapy.
I've always had essential tremors since I was a child. In a work setting, I need to write, I need to be able to sign contracts, I check into hotels, and the shakes hurt. I mean, it makes it very difficult for me to get through those parts of life. I found on the internet the procedure involving the focused ultrasound, and it was really compelling. I don't have to have a traditional brain surgery. The first thing I'd like to do after the treatment is to sign my name. It sounds really simple, but it's a wonderful thing for an individual who struggled to sign your name when you're trying to check into a hotel, rent a car, or do anything. So if I can sign my name without having my hand shake, that's going to be wonderful.
So just hearing this experience, so like the goal of therapy is truly to improve the quality of life, right? So you can see some things that are simple, such as writing, but also essential like eating properly and activity of daily living. So currently, the focused ultrasound has completed over 20,000 therapies worldwide. So it's really gained a lot of experience, and you can see on this graph how like the popularity has increased a lot in the last few years. And then I mentioned that we wanted to wait until finding out about more results on longevity of the therapy. So the next few slides are about the 5 years outcome, for this therapy, and so it's been published now in multiple journals. But essentially, about 73% of tremor improvement is maintained after at the 5-year mark. And there was no serious adverse events, that were reported at that time frame. After the treatment, so the common side effects that we hear from patients are headaches. About half the subject will experience some headaches from the delivery of the therapy. And occasionally patients can experience some numbness in the contralateral side that was treated, and some gait imbalance. The good news is that the majority of those resolve quickly within the first month after the treatment. At 5 years, there are no new adverse events, like we said, that have been reported. There's some persistent adverse events that were reported, but those are mild to moderate. Most of the time, it's some numbness or tingling at the site that was treated. So these graphs show the publications that were done from which INSIGHTEC gained FDA approval for the treatment. So the first study was published in New England Journal of Medicine, and it shows on the top layer in the graph A and graph B, so improvement in disability after the treatment. And so this is for the first year, so you can see at baseline, then 3 months and 12 months. And in blue is the results from the focused ultrasound treatment. In the red bar, it's a sham treatment that the company had perform in order to obtain FDA approval. So you can see how the disability score has a drastic improvement after the immediate treatment from focused ultrasound. And on the right-hand side in B, so the improvement in disability and percentage are broken down into different activities. So as you saw in the video, writing is a big one. So like you can see the improvement after the treatment. But other ones that are critical, such as eating, drinking, just hygiene, essentially the activity of daily living. And often what we hear is that patients regain significant portions of their lives where they feel like they can venture out, return to social activities that were initially stopped because of the presence of a tremor. Oftentimes where the patient is, self-aware because of the condition that they have. The bottom graphs on C and D is essentially a quality of life metrics. So you can see significant improvement after the treatment with ultrasound. So improvement at least 50% in quality of life in many different aspects of their life, but predominantly psychosocial, as well as physical and hobby and leisure. And work in finance, because for some patients, especially on the younger ones that we treat, will be able to stay in their work and continue performing their job, so without retiring. In the second graph, we show here the breakdown again of like the severity of the tremor. So this is a score of the tremor severity analyzed by neurologists that are blinded to the treatment category of the patient. So they look at videos of the patient and determine the severity of their tremor. And so here you can see the difference is that instead of just showing you the breakdown over a 1-year period, we show it by year and up to 5 years. And so what's important is to show that the benefits that you see initially after the first year are indeed maintained throughout the study of the 5-year period. So just going over the treatment day, so what happens to the patient at the time of the therapy. So essentially for the patient is obtaining an MRI with the difference that the frame and the helmet is attached to the head.
During the treatment, you will lay down on the treatment bed inside the MRI scanner. The medical team will be in the control room, and you will be conscious and able to communicate with them. Your head will be positioned in the focused ultrasound helmet, which is filled with water, and you will have a blanket to keep you warm. You will be given a stop sonication button if for any reason you want to stop the procedure. MR images are taken to plan the treatment. Your physician will first apply light doses of ultrasound energy to identify the right spot in your brain for treatment. Then, full intensity ultrasound energy will be applied. The treatment bed will move in and out of the MRI. After each application of ultrasound energy, you will be asked to do tasks such as drawing spirals. This is so the physician can evaluate the improvement of your tremor and any potential side effects.
Very well, so just going over the steps one more time. The initial step is the placement of the head frame. So this does require shaving the hair completely because ultrasounds are traveling through space, and it's the presence of any bubble of air would impede how like the sonification is taking place. So to make sure that there is a uniform transfer of all those ultrasound to that precise spot, the hair has to be shaved so that the gel pad is then applied to the head. A head frame is then secured in place to prevent any movement during the treatment. And then the patient undergoes the MRI. We look at the images precisely, and then we locate that one precise spot that we want the therapy to be delivered. Then we perform that target dose where a smaller amount of stimuli of ultrasound is being delivered to the location to then test and see that indeed the tremor does get better, to confirm that there is no side effect. And so once that is completed, then the full energy and the full ultrasound is being delivered. The patient receives the therapy, and the treatment is then completed. Following that, we remove the frame. The patient can then be discharged to go home. And again, you can see here a patient lying on the MRI, essentially similar to getting an MRI scanner, except that the head is fixated inside this frame so that there's no movement at the time where the ultrasound therapy is being delivered. It's some of the benefits of focused ultrasound over some of the other procedures that we do perform. So you do experience the immediate and durable tremor improvement. With DBS, for example, most patients have to wait approximately 30 days after the surgery is being performed to let the brain heal from the insertion of the electrode prior to receiving the brain stimulation treatment. There is a significant improvement in the quality of life, as we have shown on the prior graph. It is an outpatient procedure, so the patients are discharged home on the same day. For those patients who have high risk of infection, so we do have patients occasionally who suffer from severe uncontrolled diabetes, for example, or have ongoing infections that are chronic, for a reason or another, or are high risk of infection. And then for those patients, focused ultrasound is a better option oftentimes. Not that there is a concern, of like infection at the time of the procedure or surgery, but the DBS, since it's a implantable device, has a higher chance of getting infected at the time of the surgery or shortly after, and sometimes in a delayed fashion later on. So that speaks to the benefits of having no implants, as a risk for infection. The other side effects or problems of having implants is that it does require management. So the patients have to return to the clinic to get reprogrammed at times. And the device has to be replaced approximately every 3 to 5 years. So for those patients who undergo DBS, the battery typically runs out every 3 to 5 years. So it's a small procedure, but it does require coming to the operating room to get the battery in the chest replaced with a new device. Now, there are rechargeable systems that do last 15 years plus, but in those cases, the patients have to remember to charge the device. So you're a little bit more tethered, with the deep brain stimulation system, whereas this therapy here allows you to have no implantable device. There's also no anesthesia, so for those patients who are potentially higher risk from a cardiac or pulmonary standpoint, having more conditions, for heart failure or COPD for the lungs. So perhaps anesthesia would represent a higher risk of having problems, so this may represent an advantage as well. This videos shows a little bit here how the benefits, right? So are still immediate after the procedure. You can see the patient still has the bandage from the placement of the frame. So the placement of the frame does require 4 pins that are inserted through the skin to sit and immobilize the skull. And you can see here the patient was shaved, for the procedure. Oftentimes patients ask us about insurance coverage. Our understanding is that Medicare has excellent coverage for the procedure across all the US. Most private insurance are also covering the therapy fully. We encourage patients who are interested to either contact their healthcare coverage plan to see if the therapy is being covered. Alternatively, if you're interested, our staff can also help out guiding along the way to see how much coverage you would receive. So the second site is something else that came more recently as well. It's relatively new. So it's important to mention that with focused ultrasound, what we have discussed so far, only one side is being treated. So at a time when the patient goes home after that treatment, only one half their body is treated for the tremor, which means that the other side still has full tremor. Now the company has received approval recently to treat the second side. So some of the patient requirements to receive treatment for the second side are very similar to the qualification to receive the first treatment. So essentially a tremor that's resistant to medication and that is disabling. The patient also must be over the age of 22. One difference is that you have to wait 9 months from the first treatment. So patients who receive one side treatment will have to wait about 9 months prior to receiving the second treatment. What the study have shown thus far is that there's approximately 80% tremor improvement on that second side that is maintained after 6 months. And so when we look at the sub-score for tremor control, about 65% of the tremor improvement. And on the disability score, so approximately 75% improvement on disability after receiving that second side treatment. Some of the side effects are very similar to the first side treatment. So some numbness, some tingling that are seen. Some of the differences is that when we treat the second side, there's a higher incidence of having speech impediment. So typically a slurred speech, and ataxia, meaning some gait disturbance. So we see those same side effect after deep brain stimulation. So these are expected to improve, after the therapy is being delivered, but to be aware that after the second side, some of these side effects can occur. And it's part of the reason why it's important to wait, several months after receiving the first treatment to give a chance for the initial side to fully heal before subjecting the second side of the brain to the treatment. And so giving that lapse, then it reduces the chance of having these adverse events after the second treatment. So this is just an overview here of the trial that was performed by INSIGHTEC, where they gained the FDA approval for that second side treatment. So they had 50 patients that were treated. The age was about 73, and the patients had to wait, in this case, over 2 years, because there was no approval at that time. So 2 years between the two treatments. In summary, focused ultrasound is an important option to improve tremor and, importantly, quality of life for patients who have been suffering from essential tremor. And importantly, the benefits are sustained and maintained at least up to 5 years after treatment. Although, as you can see from one of my first slides, the treatment has been delivered now in 10 years, and we do have confirmation that those patients still receive benefits from the treatment. Some of the advantages of focused ultrasound over deep brain stimulation in particular is that it's incision-less. So for those patients who are at increased risk from receiving a more invasive type of surgery, so that could be a beneficial approach. So for example, patients who have chronic use of anticoagulation, so blood thinners, things of that nature, perhaps focused ultrasound could be a superior approach. There's no anesthesia involved, again, so for those patients having high risk from a heart perspective or lung perspective, or just wish to avoid surgery altogether, this could be an attractive option. And there's no implantable device, again, so you feel like perhaps less tethered. So if you travel a lot, you don't want to have to deal with charging a device, or you feel uncomfortable about the need of having surgery at time to replace an implantable system. So then focused ultrasound may be superior. Some of the advantage, perhaps, of DBS over focused ultrasound could be that we have to keep in mind that with DBS, some of the programming may sometimes be advantageous because it allows the therapy to be modulated. So at times we can perhaps achieve even higher control of the tremor for some patients because the side effects can be more in control with a reduction of the stimulation, so it's more adjustable. So we do have, we're happy to offer this treatment option for those patients who do suffer from essential tremor that's been refractory to medical treatment. And we have our contact information. On that website, there is a contact us paragraph where you can import your information. If you wish to make an appointment, we can discuss, if you'd be a candidate for the therapy, and we can discuss the pros and cons, of either options. And so this is our phone number as well, if you wish to make an appointment. And with that, we'll take any questions.
Thank you, Dr. Langevin. Thank you for the presentation. And Dr. Diaz, thank you both very much for being here and for your time. For those of you that are listening, you can still, if you have any questions, please submit them. It's at the bottom, kind of right, staggered on your screen. All you have to do is press the Q&A, enter your question, and then I'll be able to read it. So right here, one of the first questions is, can it be an essential tremor if it is also at rest? So
Yeah, so I'll take that. So traditionally, essential tremor is happens when people are holding something like in posture or with action. Now, we need that for diagnosis, and people need to have that. But over the years, what can happen is some people with essential tremor can have a spillover into rest. And especially if there's, years with the condition, or if there's a strong genetic component runs in families, sometimes people can also have a little bit of a mild rest tremor. And so those are the people that sometimes can be a little confusing, if they have subtle other things that are a little bit of a rest tremor, a little slow movement, little changes in their walk as they get older, and they have, essential tremor, but then they have these other features. So rest tremor can, for some people, be a part of their tremor, but if they solely have rest tremor, then we're likely not looking at essential tremor. We're probably looking at Parkinson's.
thanks, Dr. Diaz. Another one here. So I've had FUS and it worked well for a few months. Can I have FUS again? Dr. Langevin, like to field that one?
Yes, I can take that one. So, it would be recommended to repeat the treatments. The FDA approval does not cover that currently. And probably, repeating a telemotomy where it's already been performed could probably increase the risk of having permanent side effects. So it's a case-by-case basis, when patients had initial therapy and then things didn't work out long-term. But perhaps we'd have to confirm, first of all, revisit the diagnosis with our expert to confirm that the correct diagnosis was obtained, that nothing was missed. And if another treatment was performed, perhaps considering off-label use of deep brain stimulation to augment the effect of the initial treatment from focused ultrasound.
Got it. Thanks for clarifying. There's another, it's not really a question, but it says, I was in the original studies at Stanford that got FDA approval for both sides. One of the best decisions I've ever made. Not 100% tremor control, but can do almost anything. So that just speaks to if you're a good candidate for focused ultrasound and you're able to get the procedure, that it really can be a life-changing effect. So thanks for that comment. Another question is, can any neurologist use FUS or only specialized clinics?
Yeah, I can take that one. I think that it speaks to actually one of the advantages, I would say, of focused ultrasound that we haven't discussed in the presentation. So thank you for the question. It's the fact that there's no implantable device that goes in the patient. So although focused ultrasound is only delivered in specialized clinic, so that's why we're going to be offering the therapy. The good news is once you receive the treatments, it's a one-shot deal. So you can then return to your neurologist to treat any residual or any additional symptoms that you may have, but you're not tethered to the area where you receive the treatment. Whereas if we do deep brain stimulation, for example, you have an implantable device that requires management typically by your treating neurologist. So oftentimes, if the treating neurologist is uncomfortable or unable to program the device, then you may not be able to see your provider anymore, and you may have to switch. With focused ultrasound, you don't have that problem because there's nothing to manage. So it's a one-time treatment.
Thank you very much for that. Another one, this is my first time hearing about essential tremor and would like to learn more. What should be my next steps? So it seems like this person doesn't maybe have a primary care physician, but hasn't really seen a neurologist.
Yeah, absolutely. So, you can go to the Essential Tremor Foundation. That's a good resource if you think you might have essential tremor. I would start first with your primary care doctor and have them give you a referral to neurology. Primary care doctors also will run a battery of blood, they'll send off blood work for some of the things that I mentioned. Looking for, thyroid issues, other medical conditions, do a good screen of your medicines and make sure that there isn't anything else that could be causing your tremor. And then if you have a tremor, I would recommend that you ask them to give you a referral to a neurologist.
Thanks. And this is probably another question aimed at you, Dr. Diaz, but I was recently diagnosed with essential tremor. What challenges should my family and I expect with this diagnosis?
Yeah, so I mean, there can be a whole spectrum with essential tremor. I definitely have lots of patients that have had mild tremor for all their life and they manage and they don't need any treatment. So, please don't take away our presentation from saying that everybody from tremor that has tremor is going to need, a surgical option. There's definitely a lot of patients out there that have tremor that, their tremor, bothers them a little bit, but they're able to manage all their activities. Over time, some patients, the tremor can get worse. And that's where, seeing a neurologist to discuss some of the medical options, some of the assistive devices that we have, getting, some physical and occupational therapy can be very useful. Making sure that the diagnosis is correct. For example, like I said, sometimes people can be on medications that can bring out tremor. And so sometimes switching those medications, or if you have thyroid disease that's been undiagnosed and getting that treated, sometimes that can be very useful. So I would start first with getting information and just realizing that, there's a lot of people out there with tremor that just, they don't need treatment. They have mild tremor and it doesn't necessarily get worse. Our presentation today is to inform patients, and for those patients that, they have tremor that's really impacting their life, to understand that there are a lot of choices out there for people now.
Thanks, Dr. Diaz. I have one here. How long is the focused ultrasound procedure?
So so the procedure takes approximately 2, perhaps 3 hours. A lot of that time is spent with preparation, so placing the frame, but also delivering the small dose, subtherapeutic dose, and then checking the effects to confirm that we're having a good result. But the delivery of the therapy is actually relatively short in of itself, but the entire procedure is approximately 2 to 3 hours.
Got it. And then someone's asking, are you able to be put under anesthesia for this if you're claustrophobic, or is that an option?
It's not something that would be recommended. It's similar idea with deep brain stimulation, because with essential tremor, we really like to test the therapy. So that's why we like to have we need to have the patient awake so they can participate with the exam, confirming that we're in the right spot, and also confirming that the patient is not any side effects. So unless it's a very particular case, it's not something that we would recommend to do it under general anesthesia.
Got it. And again, for those that are listening, there's a couple of questions left. You could still enter your questions down at the bottom of the screen. Please enter it and I'll be able to see it. Someone's saying, my tremor gets better and also it gets worse. Is this typical?
Yeah, with any sort of tremor, there can be a lot of variability from day to day and situation to situation. Tremor is one of those symptoms that, depending on a lot of different things, how rested you feel, or if you feel fatigued, if you're anxious, if you've drank a little bit more caffeine that day, if you've had a little bit more sugar that day, there can be a lot of variability in somebody's tremor day to day and depending on what they're going through. So that is very common with tremor.
Got it. If I'm coming from out of town, how long should I expect to have to stay before or after focused ultrasound surgery?
That's a good question. So it's an outpatient procedure, and I would probably, to be on the safe side, plan to stay in town 1 to 2 days, after the procedure is completed, to make sure that you're completely comfortable. It depends, how far away you're coming from, but certainly if you take the airplane, to be sure that you're comfortable, like going back to the airport and carrying your luggage, I would probably wait approximately 1 to 2 days.
Great. Let's see. Does Medi-Cal cover the procedure? Because we know Medicare fully does, but does Medi-Cal?
I'm not familiar actually with that one, but
so what we're seeing is at the current moment, Medi-Cal it's quite challenging to get covered. I would still say, if you're interested in FUS, we could still pursue it. But at this time, I know Medi-Cal is pretty challenging to get coverage, unfortunately. I'm waiting to hear if I am a candidate for focused ultrasound. If I am not, how long do I wait to see reevaluate them, if they could get a reevaluation of their condition?
I think this question, it's going to depend as to why someone would not be a candidate for focused ultrasound. So it could be like the diagnosis is uncertain, or that the condition is not severe enough. So I would say that we really want to be comfortable that the diagnosis is secure, prior to performing the focused ultrasound. So at times, there's additional tests like Dr. Diaz presented earlier in her slides that can be performed to help, with the diagnosis.
Awesome, thank you for that. And lastly, if someone feels like they are a candidate for focused ultrasound, what would be the best way about moving forward, about getting a consultation, et cetera?
Yeah, I would say that the website, by entering the information on the contact us form, or calling the phone number. I don't know if we still have the slide up.
Yeah, it's all right there, and I could double down on that. Everyone who's listening, if you put in that pacificneuro.org/FUS, it'll bring you to the Pacific Movement Disorder Center page. And if you scroll all the way down on the page, it'll say schedule a consultation. So if you feel like you might meet some of this criteria that Dr. Langevin and Dr. Diaz have been talking about, you could fill out your name, your phone number, your email, et cetera, and then the office will get back to you within a day or two. So that would be the best way forward if you feel like you might be a good candidate for treatment. And also there's the phone number listed below. So with that, if there's no more other Q&A, thank you, Dr. Diaz, Dr. Langevin. Thank you guys so much for your time. And thank you everyone for coming.
Pleasure. Thank you.
Bye, everyone.